Hey everyone, and welcome back to the Complete Dentures 1 course at New York City College of Technology, Department of Restorative Dentistry. This is lecture 6 in the set. It is on achieving a proper maxillomandibular relationship record for edentulous patients and classification systems, specifically angles classification systems. As a review, I want to cover a few things from last week that may not have been covered in depth within the video or the short, brief lecture that was posted. So just to cover a few points, when we talk about our average heights and measurements of occlusal rims, for your exams, we're explicitly referring to the Air Force manual, although there are different schools of thought on measurements such as widths of the occlusal rims. The exam will be based on your Air Force manual. So given that, make sure that you are familiar with those measurements within the text. On the maxillary, the anterior height should be 22 millimeters from the labial flange, besides the labial notch to the occlusal plane. So you're measuring from the deepest part of the labial flange there. Okay. The labial surface of the rim falls on a line that drops from the sulcus perpendicular to the plane. So the Air Force talks about a perpendicular relationship as far as anterior flare on the labial surface of the rim, while maybe in lab some of the instructors have shown you that the maxillary should have a slight anterior flare. Once again, we're going to follow the Air Force manual when it comes to the things that are on your exam, and please remember that you do have a midterm next week. So then we have average widths. The posterior height first is 18 millimeters from the deepest point of the buccal flange, and the widths in the posterior are 10 millimeters, and the widths in the anterior are 8. You had these measurements in previous instructional videos and in the occlusal rim lecture. When it comes to your mandibular occlusion rim, we're looking at an anterior height of about 18 millimeters from the labial flange. The labial surface of the rim falls on a line that extends from the depth of the sulcus perpendicular to the occlusal plane. And when it comes to widths, they're about the same as the maxillary, 10 millimeters in the posterior, 8 millimeters in the anterior. What should be said here is that the wax rim in the posterior is flush with lines scored on both of the mandibular record bases, 2/3 up the way of the retromolar pads. So as you see, the posterior occlusion rim, once again, does not have a numbered average measurement. It is more an area. Each patient will differ because everyone has different shapes of anatomical landmarks. Their whole anatomy is all different. So the general rule is that the posterior height of a mandibular occlusion rim should not exceed 2/3 the way up the retromolar pad areas. Okay. So once again, these occlusion rims, as we discussed last week, once they are complete, they get sent to the clinician. Clinician then inserts them, as you saw in the complete denture journey videos, the clinical appointment where the doctor adjusted these occlusion rims and gave you lines such as your midline, canine line, things of that nature. You can see here in another set of illustrations that during the patient's appointment, the dentist modifies the shape, height, and thickness of the occlusion rims in keeping up with the person's appearances and functional requirements. Right? And this is also something that you saw in the video previous week. Once again, instructions that are given to us on these occlusion rims, areas that are important for us to see as technicians are the midline, right? That is obviously the center of the patient's face, and we know where our central should be positioned. Our high lip line, that tells us where does the lip reach during the biggest smile the patient can make, right? That kind of helps us guide with how big our teeth should be. We don't want the patient smiling and having all wax or gingiva showing. Then our canine lines, also known as eye lines, because on average, most of the time, these teeth line up with the inside of the eye line, right? Almost like the ala of the nose on the sides. And obviously, like we spoke, they'll contour labial contours and achieve occlusal vertical dimension. All right. So when we look at the correct positioning of an occlusion rim, you'll see, as it spoke about in the Air Force, that the occlusion rim is perpendicular, right? When it comes to a labial flare, we just spoke about that on the maxillary. So if we look at the first image to the left, we see that these maxillary rim are not too far forward, right? They're perpendicular to the occlusal plane, which then in this illustration promotes proper lip support, right? So in the next image to the right, the teeth are properly set in wax, so you see that the tooth now is positioned exactly where that wax rim fell. Now the issue with not positioning these teeth correctly, if you put the tooth in front of the maxillary occlusion rim, you end up with too much lip support, right? And too far in, you end up with not enough. Some terms I want to go over that I would like you to be able to distinguish between is the vertical dimension and occlusal vertical dimension. Now, when we review these terms in the Air Force Manual, vertical dimension is defined as any measurement of vertical distance made between the upper and lower jaw. A mandible can travel and stop anywhere on a path between maximum opening and closure. If a vertical measurement is to have meaning, it should identify a place along the potential path of travel the dentist and the patient can find on demand. The term vertical dimension with no further description of conditions is meaningless. All this means is that when a patient has no teeth, there is no stop, right? When we open and close our mouths into contact, our teeth touch, which hold our quote-unquote occlusal vertical dimension. But without teeth, we would close until our gums touched. So what this is saying to us is that since the lower jaw can stop anywhere on the path as it closes and opens, vertical dimension is a term that is meaningless to us because we are looking to achieve a very specific opening measurement, not just anywhere on a path. So if vertical dimension can be established anywhere, then that's not what we're looking for. What we're really looking for when we are restoring a fully edentulous patient is occlusal vertical dimension. And we've talked about this term before. The acronym commonly used for this is VDO. Okay? So as the Air Force defines it, occlusal vertical dimension is the vertical distance between the upper and lower jaws when natural teeth or denture teeth are in MI. MI standing for maximum intercuspation, meaning teeth in the most possible contact between one another as possible. The presence of teeth, natural or artificial, controls how far the mandible can travel vertically towards the upper jaw, right? So when I close my mouth now, what's stopping me is my teeth. So this is the measurement that we're really looking for in performing our occlusion rim visit. We want to establish VDO, right? The space that should be taken up by denture teeth the way that natural teeth used to. So occlusal vertical dimension, VDO, once again, is the term that we are using here. Vertical dimension in that sense, once again, is meaningless because your lower jaw can stop anywhere. We're more geared towards needing to understand how much space is taken up by the previous natural teeth and how much space should be taken up now by the denture teeth. And that is occlusal vertical dimension, once again, VDO. Another term that is very important when it comes to working with edentulous patients and complete denture work is centric relation. Centric relation is defined as a maxillomandibular relationship in which the condyles articulate with their respective discs in the anterior superior position of the glenoid fossa against the articular eminences. Now, why is this term so important to us? All this means is that centric relation is tied to condyle position in its fossa, right? While we talk about centric occlusion, a term you might have heard in other courses, is about a tooth-to-tooth relationship, centric relation is about a condyle relationship, right? How the condyles sit within the fossa. Remember, the patients we're working with do not have any teeth, so they do not have a respective position that they can repeatedly go to. The lower jaw is free in movement. It can go and stop anywhere it pleases. In that way, the only way a clinician can achieve a relationship that is repeatable is through centric relation, right? They can position the condyles in the glenoid fossa the same way each time, which is centric relation. That gives a repeatable position for the clinician to check consistently throughout the appointments. And that is why when we are taking these types of relationships with edentulous patients, we are specifically referring to centric relation and not centric occlusion. Once again, occlusion has to do with teeth. Centric relation has to do with a condyle relationship in respect to the glenoid fossa. So that will cover the quick overview of last week and getting into a little bit more about the theory behind what we're trying to capture and what clinicians are trying to capture during these appointments, and what we as technicians need to know in order to perform these tasks properly. Okay. And now we talk about angles classification systems. These are the basic 3 classification systems directly related to first molar position, but these are important to know because classifications, depending on each patient, will be different, and the way you set these teeth is also different. So right now we're just briefly going to cover what these classification systems mean and how to differ between them. So initially we have our class 1. Our class 1 is a normal occlusion. You'll see here a dotted line on that image where the teeth are meeting one another. The general rule of a class 1, as we'll talk about, is that mesial buccal cusp of the maxillary first molar is aligned with the mesial developmental groove on the buccal surface of the mandibular arch, right? And then we move to class 2. Our class 2 is a retrognathic, meaning that the lower arch is retruded back. So it is further displaced backward in relationship to the maxillary. So what does that mean? If we look at our dotted line, which is across once again, the mesial buccal cusp of the maxillary, since the lower jaw has moved backward, now that mesial buccal cusp in relationship to the mandibular molar is now forward, right? It used to be in that developmental groove where you see the distal buccal cusp now, but now it has moved forward in between the embrasure of the second premolar and the first molar on the mandibular. And then our class 3. Our standard class 3 is protrusive in nature, meaning that the lower arch, the mandible, is pushed forward in front of the maxillary, commonly referred to as kind of like the bulldog look. We have, in this case, where the lower jaw has protruded forward, our mesial buccal cusp on our maxillary is now in alignment between the embrasure space of the first molar and second molar on the mandible. So you can see that relationship of the mesial buccal cusp of the maxillary and how it pertains to where it falls depending on the classification within the angles classification system. So as we move forward, just keeping in mind that there is a graduated classification of complete edentulosum that has developed that describes varying levels of loss of denture support structures. So that is considered to be a different type of classification system. We're not going to cover it currently, but there is a classification system that kind of labels the type of resorption patterns that have occurred. For now, we're just going to more so talk about the angles classification system and also kind of talk about these resorption patterns and what occurs because of them. Okay, so completely edentulous patients exhibit a broad range of physical variation and health concerns. Classifying all these types of edentulous patients as a single diagnostic group is insensitive to the multiple levels of physical variation and the different treatment procedures that are required to restore function and comfort. So what does that mean? As you see, these resorption patterns are, when it comes to the maxillary, the bone will resorb up and inward towards the palate. And on the mandibular, when resorption occurs on the bone, it occurs downward and out towards the buccal. So what does this translate into? Well, if this is a trend that happens consistently and equally, eventually your mandibular residual ridges will be wider than your maxillary. So that means when setting your denture teeth, they no longer can be over the center of the crest of the ridge unless the classification of angles classification changes. So as we proceed, we take a look at a mandibular denture setup. Everything is not always what it seems. It's very hard to diagnose without seeing what's underneath. And in this situation, this patient has had severe resorption and bone loss on the mandible. So this denture seems to be quite tall. With the assumption that there's bone underneath, this looks like a pretty traditional denture. However, once that wax trine is removed, we see that this patient has had significant bone loss on the lower. And due to that, no matter how well this denture is made, it will never have the good retention you're looking for on a mandibular denture because the patient just simply does not have the oral anatomy that supports the retention that's needed. In this situation, you would be looking for possible implant solutions, trying to get a denture that does not move around in the patient's mouth and that can be functional. However, socioeconomic statuses and financial situations can prevent patients from achieving this, and unfortunately, this might be their only option. So once again, we take a glance at these angles classifications, class 1 being normal, class 2 retrognathic, meaning that the lower jaw has protruded backwards in relationship to the maxillary, and then our class 3, which is prognathic, the lower arch has moved forward in front of the maxillary. Okay, so when we look at the text, this will kind of break this down into exactly what these relationships are. This is something that you do need to know and understand for your exams. So class 1, the patient's profile is characterized as normal. Once again, the mesial-buccal cusp of the upper first molar falls onto the buccal groove of the lower first molar when the teeth are in MI, once again standing for maximum intercuspation. In the anterior area, the normal range of horizontal overlap is about 2 millimeters. Horizontal overlap meaning the space between your maxillary anterior teeth and your mandibular anterior teeth, right? What's the space between those areas coming straight across, right? Another term for this that's used is overjet, right? Overjet is horizontal. When I was in the program, I was taught to think of a jet. How does a jet fly? Horizontally across, right? So overjet is across. And then when it talks about vertical overlap being 1 to 5 millimeters, that is in perspective to your overbite is the term that's used for that, meaning how much of your maxillary teeth cover your mandibular anterior teeth, right? So you have your overjet, which is a horizontal measurement, and your overbite, which is the vertical measurement, okay? Our class 2. In this class, a patient's profile is deficient in the chin length and characterized as a retruded profile. As we look back, we can see that we have the lower jaw retruded backward, okay? Now, the mesial-buccal cusp of this classification has the upper first molar falling anterior to the buccal groove of the lower first molar in maximum intercuspation. In the anterior area, horizontal overlap in excess of 10 millimeters are not uncommon. Okay? Since the lower jaw is retruded back, you're going to have a significant increase in your overjet measurement. Vertical overlaps where the lower incisors make indentations in the gingiva of the palate happen occasionally. In any event, the most significant feature about the anterior tooth relationship in class 2 is marked with horizontal overlap. So with class 2, there are 2 subdivisions. It's important to know these. So our class 2 division 1 is specifically about how the maxillary incisors are positioned. And in division 1, the maxillary incisors have a normal labial-lingual inclination, or they're too labially inclined, meaning inclined forward, okay? Then we have a class 2 division 2. Our class 2 division 2 is when the 2 or more maxillary incisors are tipped palatally. So once again, division 1, we'll take a look at this in a little bit, is with anterior teeth flared too far forward labially, and division 2 is when they're tipped backwards towards the palate. That is the difference between a class 2 division 1 and a class 2 division 2. And in class 3, this patient profile is excessive in chin length and characterized as prognathic. The mesial-buccal cusp of the upper first molar falls posterior to the buccal groove of the lower first molar in maximum intercuspation. So in the anterior area, the upper and lower anteriors usually are edge to edge. That's a common term, meaning that there's no vertical or horizontal overlap. So the overjet and overbite measurements would be 0. We'll look at this in a little bit throughout this presentation so you get a good visual of what this may look like. A negative vertical or horizontal overlap is possible with this type of classification of bite, and we'll see that in some of the photos to come. So here we have a very typical class 1 occlusion. You can see on the side profiles, on the lateral shots of this case, you can see that once again the mesial-buccal cusp of the maxillary is lining up on that buccal groove in the mandibular. You have a very traditional overjet overbite measurement of about, I'd say this is probably 2 millimeters to 2 millimeters, a 2x2 as some professionals would call it. And this is once again a very basic setup. Then we have our class 2. These are very common as well, where we have Lower jaw retruded backward. We can see here in the images of the lateral views that the mesial buccal cusp is anterior to the buccal groove of the mandibular first molar, right? So, and we have a severe overjet, right? That's definitely a sign that this is a class 2 occlusion. Here we have another severe class 2. Sometimes class 2s from a frontal perspective, from a facial perspective, you can see that if set correctly, it's not as noticeable that patient is really in a class 2 occlusion. It becomes really noticeable once the patient is seen from a lateral perspective. Sometimes this is very well hidden intraorally. Many people won't even notice a class 2 relationship. However, you can see on the articulator that the overjet is severe. I would say probably over 10 millimeters in this respect. So this would be considered to be a typical class 2 division 1 where your maxillary teeth have the proper flare, and we're just talking about lower retrusion. The mandibular arch is backwards in relationship to the maxillary. So another one that would be considered a class 2 division 1, once again, is this case. You'll see that this patient has severe deterioration, periodontal disease. Most teeth are periodontally involved, needing extraction. You see the mandibular molar there on the lateral perspective of the patient's left has impinged on tissue on the maxillary. So these types of cases are usually going to turn into what we call immediate dentures. These teeth will be extracted on the model, and then dentures will be made. In this situation, you can tell that there is some severe overjet from a lateral perspective, and also you can see that the maxillary teeth, remember, are tipped too far palatally. So since they're so tipped palatally, this could be considered a class 2 division 1. Now, depending on the severity of the classification, this patient seems to possibly have been in a class 1. Classifications can change depending on your current oral health status. So because this patient has teeth that are periodontally involved, teeth have shifted, teeth have moved kind of into a class 2 relationship, division 1. However, the bone structure still allows us to fix this and create it into a class 1 occlusion. So classifications are not set in stone. There are situations where a class 2 or class 3 can be converted back into a class 1, which is sometimes very much preferable by the clinician. Next, good look at a division 2 class 2. What we were looking at is that if we notice that 2 or more teeth in the situation are extremely palatally tipped, they talked about what we just went over, that sometimes you'll see teeth impinging on gum tissue because of severe either reduction of an increase in overbite, or you'll see that the maxillaries kind of completely overlap the lower incisors there. So you'll see that those 3 teeth, your centrals and your lateral in this situation, are completely tipped palatally, which is the telltale sign of division 2 occlusion. And you'll see where the red arrows are that the mesial buccal cusp once again has moved anterior to the buccal groove on the mandibular first molar. So all those things tied together give you a class 2 division 2. You have your mesial buccal groove in front of your mesial buccal cusp on your maxillary that is in front of your mesial buccal groove on your mandibular first molar, and you have 2 or more teeth that are palatally tilted. That is a class 2 division 2. And then we have a class 3 occlusion. This was done by a good friend of mine. He received this case as a class 3 occlusion. You can see the pre-existing dentures and how they've worn into one another. And this patient is definitely a class 3. In this case, it is so severe that this cannot be fixed into a class 1. So as we move forward, we take a look at the tough case that it is. And my buddy has been able to set this in a more aesthetic value. This was just a wax try-in, so things were changed, and I believe the patient went home happy. So once again, just recap, your midterm is next week. Please cover all of the things up until now. The midterm is accumulative, so it means this covers everything from the beginning of the semester until now. Make sure you watch all your instructional videos, and for this week you can see the pages that need to be reviewed in your Air Force. All this content will also be in your midterm. If you have any questions, please reach out, and I hope you guys have a great week. Bye-bye.